We're going to start with the MHA 575, which is our week 2 lecture, and I'm going to be sharing information I think is going to benefit you from a healthcare perspective with patient safety and patient quality, or quality of in healthcare. This is an illustration that you often see tied in with a better communication flow that we'll talk about a little bit more with team steps, but it's called a Swiss cheese model of errors. So what you're really looking at is at the far left side, poor communication. So that gets this sequence started in a bad direction. So on this event, the next thing that occurs, that there's policy, there's procedure, they were not followed per protocol, maybe the x-ray wasn't labeled, so again, several missed opportunities. The next step, next error that happens, there's teamwork failure. So maybe we didn't do a pause or a timeout to validate that we have the right patient, we have the right procedure, we have the right equipment that we need, everyone's on the same page. For whatever reason, that did not happen. And then the last Swiss cheese in the front, it talks about the orthopedic surgeon failed to examine the ankle. And again, that's a key aspect. They're supposed to do that, and the surgeon is actually supposed to put an X on the involved extremity or area that the surgery is to be conducted. So all of this transcended then to a patient received anesthesia, and it was all for an unnecessary surgery. If indeed it went to the next level where surgery occurred, this all ties into being a sentinel event where you have to do a deep dive, a drill down to find out what sequence of events transcended for this to happen and for it to actually reach a patient. Multiple errors, and again, multiple failed communication. So with team steps, again, we're talking team communication. So it's a team strategies and tools to enhance performance and patient safety. They're looking at the performance. That's got to tie in with your leadership driving the ship. We talk about the situation. We talk about the mutual support and skills. That also ties in with attitudes. Everyone's got to feel confident and comfortable speaking up so that they can be impactful and make a difference. And then also knowledge. So the group needs to have knowledge about the patient care that needs to be done, about the policies, about the protocols. And I think all of this too, you got to have that mutual respect for what needs to be done and why is it being done. Why are we following these policies? What is the why behind those steps that we're taking? The Agency for Healthcare Research and Quality, they really have provided a lot of information about patient safety and healthcare quality, so that's an excellent resource for you to tap into for additional information. Also, we shared at week 1, the Institute of Medicine, IOM for short is their acronym, one of the reports, and it was a shorter version of To Err as Human. But again, I can't say it enough how impactful this article was in the world of healthcare. This was back from November of 1999, and they were talking about approximately 100,000 patients die in the hospital each year from medical errors, and 72% resulted from communication errors. So again, that's why I want to tie that in with team steps and why that communication is so critical. I do have to say I'm seeing a lot more literature that is now saying that 100,000 patients dying in the hospital each year, that may be a low number. They have more information coming out, and I think some of them I'm seeing is saying all the way up to 250,000. So we still have opportunity. So team steps, again, effective communication is a two-way street. I can remember back in Communication 101, which actually was a class that I took at St. Mary the Woods when I was still a senior in high school. But I remember hearing about encoding and decoding, so you're getting your message, you're kind of interpreting it in your mind, and then you're deciding how to decode or return a message to that person interacting with you. So the basics are still in play. We need to make sure that we have good, solid information. We're not giving a lot of verbatim that we don't need to share, so we need to be to the point. We need to use clear language. Terminology needs to be clear. Acronyms are a lovely thing, but not everyone is going to be on the same page with that. So you really have to be conscientious and spell out what you're wanting to say for the most effective form of communication. I can't stress again that be concise, be succinct. People are very busy, so that the quicker you can get the message across is going to be more rapidly interpreted and accepted. And also just avoiding delays. You have to verify, validate, acknowledge, and truly, if you're having a concern with any of these steps and something doesn't feel right in your gut, you need to speak up. You really have to be there to represent the patient and their family, and also for your own license or for your own job, making sure that if something doesn't feel right, we need to speak up and be the advocate that the right thing happens. The information exchange method, one that we use quite often, you'll hear talked about quite a bit, is SBAR, and it's where you give a situation. We use this like if we call a physician for orders. You may tell them, what's going on with the patient, a little bit of the background, assessment, and then a recommendation. You can also even use this when you're doing charting, if you want to kind of use that. You can do a call out. I was at a program last week, and they were talking about in the cockpit of a plane, how the pilots, they will all be doing their checks and balances. As far as I know, a lot of times they say this list that they check off is like cookbook medicine for them, but that keeps them safe, and that helps protect the customers they have in flight. So again, if something doesn't feel right, they do call outs, they do cross check, they actually say check, and then if something isn't right, it will escalate up, and they'll say, Captain Smith, did you hear my question? And again, just that escalation of their process that they practice and they have honed in on, so that if there is an unsafe situation, it's going to be addressed. So the closed loop, the communication, again, that ongoing verifying, confirming the message, confirming it was heard, confirming that there was clear understanding of what was being sent. We just can't underestimate the validity and the importance of that communication chain. Leadership and culture, they also play a very tight role, and a very very important one with keeping kind of the moral compass pointing true north, keeping us going in the right direction, as Stephen Covey would say. You start off, and they talk about in this diagram about increasing informativeness, increasing trust, and that's moving you down a pathway that is going to help with strong communication. You're more proactive, and you're generating good safety ideas. Everyone's engaged, versus at the far left hand side, where you've got, there's a pathological error, there's a broken system. People are reactive instead of proactive. So again, looking at what can we constantly be doing to be moving in a solid direction, be proactive, be generating new ideas, and be helping to not only ensure safety, but also it has that level of engagement with everyone involved, and everyone's ideas are important, and that's a good thing to have, that everyone feels that sense of empowerment to have productive change. Barriers, again, looking at the team steps and ARC as far as references, some things that can kind of play into that, where you do have faulty communication. If there's inconsistency in the team membership, so you got different players at the table, that might be impactful, especially if not all the team players have been acclimated to know in a handoff situation what they need to do. If there's lack of time, you're rushing, you're pushing things out, trying to get something done, that can kind of set you up for a failure and for harm or an unsafe situation. if you don't share key information elements. If you're strictly going by a hierarchy and you don't have that empowerment of your frontline people or your people doing the hands-on work, that too can lead to a faulty barrier. People being defensive. I think it's always really easy to be reactive and to be defensive, but we need to set that aside. We need to always be appreciative and listen, because I don't know everything, and I don't think many people do. So I always appreciate if I can have someone share something with me, especially if it's going to help me do my job better or it's going to benefit a patient in this case. Sometimes conventional thinking may be good. Sometimes we need, though, to look outside the box, and we need to be pushing the envelope. We need to be seeking out what's the most current evidence, and we may have been doing a practice for a long time that historically might have worked, but then there may be those new practices, those new evidence, those new research trials that are having us go down a different pathway. So we need to stay current. We can't be complacent. I think a lot of times you sit back on your laurels, bad things can occur. We can't tolerate that. You really have to be moving forward, and you have to constantly be staying up to date with what needs to be done and stay engaged. Again, it's a fast-moving pace, rapid cycle change. We all need to be invested in that. The communication style. Sometimes it's kind of good to have various communication. Some people are really hands-on. Some people like to see something visually. Some people like combinations of many of those factors. But we all benefit when we hear it several times to get it to lock and load in our mind. So keep that in mind. Conflict, while I know it exists, we certainly are all adults and we need to work through conflict. So, having that communication, that exchange, with someone if you're having a conflict, sometimes with a physician, that's not always comfortable, but just letting them know, this is why I'm doing what I'm doing. We had this come up just recently. A physician was very upset. He thought he was actually going to be a cause of a fallout based on documentation, but what he was doing was best practice for the patient, but there was some other correlating factors of why this patient happened to fall into a chart abstraction bucket. So, I had to work with him. We also communicated his concern up the chain. And honestly, nationally, there are changes occurring because his concern of what he was doing, which again was best practice, was what should be in the specs and what should be in our standards. It just hadn't rolled out yet, and it being a new measure, there certainly was opportunity for change. So, you feel a little uncomfortable when someone's raising their voice and talking to you. And he was classy talking to me, but again, there was that conflict that we had to work through. Got to have coordination. You got to have follow-up with your coworkers. You got to close the loop. Again, that debrief. So when someone's coming on, making sure that they know what's going on, and then that handoff or debrief when you're maybe leaving a shift or passing the baton to someone else, so that again you don't drop the ball. So again, that closing the loop. Distractions. We hear a lot about this when nurses are trying to distribute patient medications. If they get distracted, that could lead to a medication error. So again, there are some facilities that actually have a quiet zone where if that nurse is in that zone, they cannot be disturbed while they're passing patient medications. So again, you got to be creative. You got to think about what is the task at hand. Is it a high-risk task where if they're distracted, that could lead to a harm or a error occurring? So you do have to think about that. Fatigue, we're hearing a lot about employee fatigue, nursing fatigue, and there's a lot of studies. I know the Joint Commission is also looking at that as well, with trying to make sure that we are monitoring the hours that staff work. It's also the same for the physicians. A lot of them are working very long hours, and you get to the point that it's not safe for you to work. It's almost comparable to you having a consumption of alcohol that has you in a toxic situation. This is also being monitored for truck drivers. So if you got a semi driver out on the road, they're having to track their hours, and if they get pulled over, they have to present their driving log, because again, they're restricting the amount of hours, because it's just not safe for them to exceed a certain designated hours per day. Workload, I think that constantly has to be evaluated. I think that staff need to speak up if they have a concern with what their workload is, and maybe they just need also to have better methods of doing their work. Maybe they aren't organized, maybe it's something along that line, but put that aside. You got to communicate, and you got to see where you're at, and then how you can maybe adapt the workload so that it's fair and it's reasonable. Misinterpretation of cues. I always think about this when I think about cultural differences with individuals. The United States, we have a nice blending of so many cultures, and we have to be very respectful of being familiar with what may be offensive to someone, may not be offensive to someone else. Excuse me. And just things of eye contact, handshakes, if we roll our eyes, as far as there's so many things that could be potentially misinterpreted. Even how we type, if we type all in bold or capital letters, and send a text or an email like that, people might think that you're yelling at them because of how that is, the font is laid out. Just a lack of role. And again, you got to think about leadership. People need direction. We all need to make sure that we're rowing the boat in the same direction. So we want to make sure that all of this communication is effective, and it is leading to effective teamwork to meet the end goal of taking care of that patient in the healthcare arena. Again, some things that can be done. We've talked a little bit about this. I already mentioned SBAR. Some other items, the brief, or you may hear it more often, a debrief, where you're again just finding out, after a situation, how did things go? We did that after week 1 of class. I asked you at the very end what went well, what didn't go well, and it's okay for me to speak up and also critique myself. I had said I was upset with myself. I did not bring the agenda, and I thought I could, wing it, and I did okay with that. But that was one thing that was a missed opportunity. So huddles, a lot of times you'll hear in the hospital settings where you'll have a morning huddle, and they're just kind of going through, what are key things going on the unit, or what are key things that are occurring in the hospital. Maybe after a fall event, they're going to have a huddle, and they're going to talk about what contributed to that patient falling, and then what could we do different, and then right at that moment in time involve the patient and their family, if they're there, to also get their input of what could be done differently to improve the process. You can't underestimate the power of including that patient and the family, because they have very good ideas and adds much value to the process. Step cross training, the feedback. I think a lot of times we don't take the time to give that feedback, and it can be positive, it can be negative, but I think that's really critical. That also gives that person a good direction. If it's negative feedback, maybe they didn't know they were doing something incorrectly. So getting them back on track, that's going to help add value to what they're going to produce with the teamwork. If it's positive feedback, who doesn't like to get a pat on the back? Who doesn't like to be recognized for doing a good job? So that's important. If you say you're going to get back with someone and give them feedback or give them an update, then follow through on your word. That's really important in this day and age with HCAPS, which is the patient perception surveys, that we close the loop with our patients and the families. So again, we need to do the same with our coworkers. Advocacy, assertion. we need to advocate. We need to be assertive if that is needed, and when we know there's a safety issue involved, or if we have a question and we know we need to get that answered to deliver the best care that we can within our healthcare setting. So again, those go hand in hand. Two challenge rule. If we challenge something, and then maybe you need to go back and you need to step it up again, and maybe you need to get more than just one person involved that you're challenging, so that again you've got a second opinion about what's going on, how is it the right thing, but listen to your gut and always be sure to I guess go to the side of caution. Cuss, we're going to talk about that on one of the next slides. The desk script, collaboration, S-bar, callback, check back, and then handoff. So a lot of variation. I think it's just good that you get familiar hearing some of these terminology and then just realizing that they do truly add value. So the S-bar, we talk about the situation. So maybe you're doing handoff to someone that you work with. So you're going to identify who you are, who the patient is, in this case, the residents. I would assume maybe an extended care facility is for this example, and then what the problem is. You're going to give a little background. What do you know about this resident? What's their history? Maybe they recently were in the hospital for pneumonia, and now their vital signs, the temperature's going up, their heart rate's going up, their blood pressure's dropping. Maybe you have some blood work back and you notice the white count's elevated. So those are pretty key findings. Your assessment, you're worried because you're seeing that temperature go up. They just were released from the hospital with pneumonia. You're concerned that their severity may be escalating. So the recommendation, you need to find out what's next. If you're talking to that doctor, do they want any additional tests? They might be thinking, if that patient was recently discharged from the hospital with pneumonia, maybe they're going into sepsis, which can be a life-threatening process for a patient if it's not quickly identified and quickly treated. So in that kind of situation, they may want to quickly get a lactate level for the patient. They may want to start a fluid challenge for them and evaluate if they're not still on antibiotic, get one started, and they may need to be rehospitalized. So that's just an example. So you can do a lot of information exchange that's programmed so you know exactly what to say and be brief, to the point, and effective. Cuss. The cuss is talking about you're concerned and you're voicing that. And again, this is an example about an extended care facility, a resident. So you're concerned about the resident. You're uncomfortable with what's going on with that condition in that patient. Safety, you're worried about they're at risk. So an example of what they're saying is, I'm concerned that Mrs. C is not her usual self. I'm uncomfortable that she's behaving so oddly. I believe she's not safe. She may have something serious going on that we are missing. They talked about also at a program I was recently attending with Life Wings, and Captain, what was his last name? Harden. He was talking about that you may even want to have a code if you're having a conversation in front of a patient or family where you're still going through this process of maybe the cuss tool, but again, you may be saying that you want clarity. So again, you might want to talk within your own work settings, having that process and having key words that, if you're saying that to a coworker and you say, I need clarity, then that may be a cue to them that, hey, I think a mistake's happening. We need to check on this, but without saying something distasteful in front of a patient or their family. So just something to consider as well to promote safety. They talk about having that shared mental model, being adaptable, that adaptability, team orientation, mutual trust, team performance. These all go hand in hand. And again, you got to really work as a team. You got to work as a cohesive group. You'll see a lot of this in sporting groups that, they have to have that same goal. What are they wanting to achieve? How are they going to get there? Do they trust their teammates? If the quarterback passes the football, is that person going to catch it? That's why they practice. They go over those drills multiple times to make sure everyone's solid. They understand their playbook. They understand what they need to do to get to that point where they trust each other. And then the team performance, it's in the game. So you watch that game on Sunday afternoon and you can see how did that all come together? How did that flow? But it takes a lot of work, a lot of practice, and a lot of dedication to get to that point. So it's no different in healthcare. These are some other really good resources, so I just wanted to be sure and share these with you so that you would have access to the information, tying in a lot with ARC and a lot with team steps for good communication. Rapid response team. They started this a lot in 2005 with the 100,000 Lives campaign. This shortly following some of the outburst of concern with the To Err Is Human information that was brought out. They're looking at a patient maybe going downhill, and they need to get rapidly a code out, called overhead, where you get key people at the bedside. They can quickly assess, treat the patient. Often what they do is they have approved protocols that they can start implementing. A lot of times a physician will be involved with those rapid response team codes that are called. But again, this has really changed the direction of a patient who is doing poorly. They're starting to go downhill. But with that initiative of the rapid response team, it really has helped prevent patients from having to leave and go to ICU. It's prevented them having to have CPR done. It's prevented them dying and having a bad outcome and not getting to leave the hospital and go home, but instead having to go to a funeral home. So this has been a huge initiative. And the moment this rapid response team started, I know at our facility, we started to see a line go extremely upward and a line go extremely downward. So the upward line on the graph was showing those patients that successfully benefited, from this rapid response team, and the amount of the rapid response team calls that we had, and then line going down, the patients that had a bad outcome. So it was very exciting to see that on paper, and it's very exciting to know so many patients that used to die because we didn't have this in place. That has reversed, and it's a very good process improvement that we have in place. The other thing they talk about with the Rapid Response Team Joint Commission, they also coupled this initiative with the National Patient Safety Goal. The National Patient Safety Goals, they do update those annually. Sometimes they'll even do it mid-year if there's a real significant event. But these are national. So again, these are kind of putting it out on the radar that, you need to have a plan in place. You need to be aware that these are on the radar. Other hospitals are having concerns with this area, and you need to think about how can we have a safe environment in our facilities so we don't have a bad outcome. So that also helped to spread this initiative. So I thought that's good to have that history embraced, not only by the ARC but Joint Commission, and again turning the boat around. The other thing, as far as including the family, I tend to always think about this when I think about Josie Wells and her mom, Sorrel. She just knew something wasn't right with Josie, and she just wasn't being listened. They didn't listen to her. So I think that we have to listen to the patient. We have to listen to the family. They also know if something isn't right or something isn't on cue with what's occurring with their family member or with the patient. So them being involved, I know we actually, when that patient is being admitted to our facility, we go through the steps that they need to take, rather, to actually activate a rapid response team, or a condition C is what we call it sometimes as well. But that will immediately get the same response where everyone can go to that room. I have to say it's not used a lot, but I think it's reassuring for them to know that they can do that, and that information is also on the whiteboard in the patient room so that they have that available. And if the family's at the bedside, it's another active reminder that, all hands on deck, that, if there is a concern, help is just a call away. So, I said Josie Wells while ago. It's Josie King Foundation. Again, just a tragic story. So what she tried to do, the mom being Sorrel, is to work with the facility of where the death of her child occurred, and it all stemmed from she had dehydration. And if only they would have listened, if only they would have ran some more tests, if only the change could have saved Josie's life. And instead we have a toddler who's no longer with us. So Sorrel King and her family, they really decided to turn a negative into a positive, and they worked with the hospital, and they actually have worked nationally and internationally to set up this foundation. Their sole purpose is to promote safety and to promote people speaking up and promoting change to happen, so we don't have another Josie that doesn't get to have her next birthday. I want to also just remind you that we have other victims. Medical errors happen, patients get impacted, families get impacted, but it's beyond that. What about the staff? This story actually came out in 2011, and it was a veteran pediatric nurse who she took her own life. She felt so distraught after a incident that caused the death of a critically ill infant by a medication error that she lost her job, and she had to go through some disciplinary actions with her licensing. She had a probation period. She was devastated. The sad thing is, we failed her as well. There was more than likely a system problem with what occurred for that medication to have reached the patient. Whether a full drill down and root cause analysis was done to find all the causative factors that played into this situation, I don't know. But in a just culture, an organization, they sit down with all the players and they find out, what happened, what in our system allowed this nurse to make this error. How does that happen? And I just wanted you to be very aware, because when a person does commit an error, yes, we have a tragedy we have to resolve with the patient and the family, and being transparent and letting them know what happened, because honesty is always the right policy. But please keep in mind the staff that work in your organization as well, because their heart and soul is into providing good patient care and to provide good environments for their patients and to do the best that they know how. So this is, in the most part, not a purposeful situation. There's always a few bad apples that you can find out about that are death angels, but that is an exception. That is not the norm. So again, this situation, when you have a true incident that happens that's accident, you've got to find out what is the system issue. You've got to have the just culture, and you can't go out attacking employees. You need to evaluate if they followed protocols, of course, and maybe there are some disciplinary actions that need to be done. But in a situation like this, don't make a fast assumption that it was just because of what this nurse did. Usually there's other contributing factors that do have to be evaluated. So last slide. Leadership. What does leadership do? And you guys are all working on your masters in healthcare administration. You guys are all maybe leaders in your work environment now and continue to be future leaders with having your master's degree. You need to really think about the macro focus, and what I mean by that, looking big, looking at the system. Don't just micro analyze that nurse. Look bigger, as far as what transcended, what happened, how did that happen. You need to keep in mind the culture of the organization. Do they eat their young? Are they accepting of new ideas? Are they accepting of feedback? Are they accepting of someone having that S bar and that cuss and that clarity to find out, something doesn't feel right? Can we talk about it? They need to be the leader for the paradigm shift. So again, it's not business as usual. Sometimes you got to get in there, shake things up, and have a new process in place that's going to make a organization stronger and move in a better direction. They need to really promote performance improvement, and the only way you can do that is constant observation, looking at collecting data, evaluating the data, and then getting that out to the appropriate staff that are going to know what happened. So you need to also encourage if there is a near miss. So obviously if an incident happens, we want to know about it. But I mean, how many times do you have a near miss? Or if you want to put a positive twist on that, you could call it a good catch. We need to know those too, because if we had a near miss that almost happened to me while I'm delivering care, that could almost happen to a coworker of mine, and maybe they wouldn't be as lucky, and that would reach the patient and cause harm in a true incident. So we need to be thinking, how can we improve? What do we need to do different? Let's constantly be thinking, having our thinking cap on, and don't be afraid to steal good ideas. I love to steal good ideas. I always have my eyes and ears open, but on the same token, I will share good ideas. So, you need to be proactive. You need to be out there on the units. They have a lot of employee rounding that we're doing in our facilities, and I don't think that's uncommon. We're asking the employees constantly, do they have what they need to do their job? Has there been a safety issue that they're aware of that we need to be looking into? Is there anyone we need to recognize? We do the same thing with the patient rounding. Do they know who their nurse is? Are they being updated on their test? Is their doctor giving them good communication? This also all flows into that patient perception survey. So you want to be proactive while that patient is in the hospital receiving care, that you're satisfying what they need to know and have done. That's what we all want. You just treat other people how you'd want to be treated. We do tracers, and what I mean by tracers, we are going around, we're looking at areas that could be at risk or could cause harm. An example of that, we've been doing a lot of information sharing about Cydex and infection control, and so we're going around to the units that they use Cydex for cleaning equipment. We've actually changed over to Trophon, where it's another equipment that will help clean soiled equipment, so that again it's sanitized and in good shape. But if we don't have that available, we do have to use the Cydex, and there's a lot of checks and balances, a lot of documentation, and it's really critical. We're talking about infection control and patient safety, so we do a lot of tracers on those areas, ones that we know are high risk, maybe high volume, maybe even the low volume, because if you don't do it a lot, that could even make it more risky. Gemba walks. This is a Lean Six Sigma term, and what it means is you're going to the front lines, you're going to the people, you're going to where the situation is occurring, and you're trying to see for yourself what's going on. You want to hear that voice of the customer. What needs to be done differently? What are you observing with your own eyes that maybe the people around you working on that in that work environment, they're blinded to it? Maybe they don't notice that there's soiled ceiling tiles, and so you go up there and you're doing a gimbal walk, and you're maybe having a very focused review of what you're looking at, such as like we do sometimes with some of the tracers. um, it may be an eye opener. So I encourage you to keep that as a tool that you utilize as well. We mentioned a little bit about just culture. High reliability organizations, this is a new buzzword or terminology that you'll hear Joint Commission talk about, and it's a good thing. It's talking about that. We are looking at safety. We are looking at involving staff. We are looking at open communication. We are looking at transparency. We are looking at how can we do things better. This moves the bar. This makes you a better place for all this hard work and all this open communication. I'm not saying it's easy, but it does present itself with a whole other good package of where you get higher satisfaction from your employees because of the level of engagement and mutual respect, and also those good generated ideas for PIs that can lead to a much better process. The non-compete when it comes to patient safety, I'm on several committees, and we all agree that we're very transparent. One, we're transparent with our data. It's already mostly out there anyway for anyone in the public to see, with Hospital Compare and also with Leapfrog with the grading system. But also, if we have a situation that happens at our facility, if I share some of the information that happens, I'm not going to breach patient name, that kind of identifying information. But if I share the story, I might help another facility not have the same situation that we did, that reached a patient or almost reached a patient. So we all agree it's a non-compete when it comes to patient safety, and that's national. I think there's probably very few areas that don't go down that path anymore. So that is all that I have for